As everyone gets settled into the Zoom room, I just want to take a moment to ensure that everyone in our audience is ready and comfortable with the technical aspects of this webinar. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language, ASL, capabilities enabled in this meeting. You can activate this by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please send a chat message to the host and we'll be able to address that for you. Lastly, if you have questions during the presentation, please enter them into the Q&A area. The questions will be directly sent to the presenters and moderators, and we'll make sure to answer those at the close of the presentation. Right, we can go to the next slide. The views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Substance Abuse and Mental Health Services Administration, SAMHSA, or the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the US government. Next slide. This webinar is being brought to you by the Crisis Systems Response TTAC. SAMHSA has selected Altarum to provide training and technical assistance support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix LLC, who have extensive experience with crisis services and technical assistance, the TTAC was formed to support the continued growth of 988 Lifeline and build a more robust crisis care system. Next slide, please. We'd like to thank our SAMHSA team who supports us in all of our endeavors. Jill Mays is the Division Director of Crisis Systems Transformation for the 988 Behavioral Health Crisis Coordinating Office. Next slide. And here is our TTAC work stream. I am Megan McGregor, and I'm joined by Bree Carr and Jennifer Sedeby, and together we're bringing this webinar to you. Next slide. All right, our objectives for today. So by the end of this webinar, we'll be able to explain the concept of a warm handoff and its impact on the continuity of care and engagement. We'll recognize the role of lived experience and peer support in coordinated follow-up care. We'll be able to describe community-informed practices that support engagement across diverse populations. Next slide. Because we're the Crisis Systems Response TTAC, we want to make sure that we identify how this webinar is going to help play into our crisis care continuum. So within our first pillar of care, someone to contact, training peers and clinicians to apply engagement tools to reflect the values and needs of the communities they served, helping to support our follow-up care. In our next pillar, the structuring of mobile crisis response teams to incorporate input and feedback from individuals with lived experience will help align with local service gaps. And in our safe place for help, we'll be able to establish partnerships with trusted community organizations that will support warm handoffs and that service continuity and supporting us in that follow-up care aspect. Next slide. We're joined today by Dr. Laura Leone. Laura is a senior consultant who's been working with the National Council for Mental Wellbeing since 2018. She's worked with children, adolescents, adults, and older adults. She brings extensive subject matter expertise in suicide prevention, intervention, postvention, evidence-based practices. She is an expert in the crisis continuum of care, and she brings her experience in organizational change and systems improvement. Laura, we're so happy to have you today. Welcome.
Thank you so much, Megan, and thank you for the introduction. Hello, everyone. Welcome. Thank you for being here and taking the time out of your days to do that. We are going to journey now and really talk through how we build community-informed practices and follow-up model. And to really start and to kick us off, I really want to hear from you. So please just take a moment and I want you to think about if you or your family were ever to receive crisis care or other health care, what do you hope that that care is like? What would you hope that that includes? Go ahead and share that in the chat and just take a moment to think about that. You would want compassion, authentically compassionate, kindness and safety, clear explanation, clear information, having people that are competent for providers and staff, being non-judgmental and holistic, and having a lot of listening opportunities, and being person-centered, having good follow-up care and no judgment, right? That neutrality, being accepting and not dismissing anything. Yes, so lots of people sharing similar comments here, right? Having quick prompt assistance without a lot of hoops for access. Being able to get connected to care right away, the type of care or needs that you need in the moment, meeting people where they're at, which could mean geographically, that could mean emotionally and mentally, or in their level of readiness. Assuming someone is always telling the truth. Excellent. I feel like we could keep going and going here, but I definitely want to share a little bit more than just this. But all of these comments that you're mentioning, they align with being person-centered. They align with the vision and understanding of what good care coordination is all about. So many of the things that you mentioned really connect to and represent what we're going to talk about today. They represent being community informed and how we really think about the individuals and the groups of people that we serve, and that our approaches should never be a one size fits all, or that everyone kind of has to do the same kinds of things. No, it should be customized and considerate. We're going to talk about what that means. We're going to talk about being trauma informed and how we understand people in all aspects and walks of life, and that we are trying to prevent further complications of life to happen, preventing re-traumatization, and all the things that are connected there. So good care coordination, this is a particular definition of care coordination that I really appreciate. It comes from the Agency for Healthcare Research and Quality, and it defines it as involving deliberate or specific organizing of care activities for an individual, and then sharing information among all providers. And when we hear providers, really think about any staff, any person as part of the team, as part of the continuum, all providers concerned with the individual's care to achieve safer and more effective care. And the individual's needs are preference, and their preferences are known ahead of time, hopefully communicated at the right time to the right people, and this information is utilized to provide safe, appropriate, and effective care. As we look at this definition, we can pull out so many of the words that all of you mentioned as what you envision good care to look like and to be like. And really truly representing what care coordination is all about. And care coordination has been referred to as the linchpin of healthcare. And just so if anyone here doesn't know what a linchpin is, on the screen is a picture of that. It is literally the pin inserted crosswise through the end of an axle or a shaft to prevent a wheel from slipping off. Imagine you're hanging out on a wagon for the day. And that's it's really another way to think about it is it's the keystone. It holds everything together. And care coordination plays a very central, crucial, and pivotal role in ensuring the success of the crisis continuum of care and then the broader healthcare delivery system. Care coordination can be seen as a key element that keeps various parts of the services and the support systems interconnected and running smoothly. Gone are the days, we hope, that where all of the pieces of the system are disconnected or siloed. We want the system to be connected. We want people's experience to be smooth and fluid and have the follow-up and the communication that is so vital and important. And we know people do better when that happens. systems and symptoms and judgments and all the complexities sometimes can get in the way of people receiving good care and smooth care. But care coordination can provide that needed expertise, that support, guidance, and advocacy to help people and to help with the navigation and movement and understanding. So, connected to all of that are these key pieces that you see here. First is connecting team members together and services. So, care coordination, when we engage in good, strong care coordination, it ensures that all healthcare staff, team members, and when we think about team, think about anyone who is involved in a person's care and services and need, including that person, working together to communicate effectively. And it's especially important for people with complex or chronic conditions who are in the middle of crises, being able to have the opportunity to talk and manage through often seeing multiple providers and multiple organizations. With improving outcomes, effective care coordination can certainly lead to better individual outcomes or person outcomes, health outcomes, by ensuring timely and appropriate care, reducing hopefully unnecessary hospitalizations or readmissions or medical errors. And it helps prevent care gaps and ensure that people receive the right treatment at the right time. Again, a great call out I saw in the chat. Enhancing the client experience, by coordinating care, a person's experience can be less confusing and less frustrating, as they don't have to manage all these multiple appointments and follow-ups or instructions on their own. It's not without support or guidance. Ideally, they have a central point of contact, which often someone assumes the role maybe of care coordinator or patient navigator or care navigator or nurse navigator, or, there's all sorts of different terminology for people in this role of that provision of care coordination who ultimately helps a person navigate the system. And over time, what we have seen is there's sometimes a confusion between what is care management and what is care coordination. Over the time, that has morphed and shifted and changed. And so someone can provide care coordination, and it might be their specific role to do that, right? They might be a care coordinator, as an example. Or it might be a function of someone's role. So you could be a medical assistant, you could be a peer specialist, you could be a case manager, a primary care provider, whomever. And a part of somebody's functioning of their role can be the provision of care coordination. So just something to keep in mind. And for those of you who are here today, like Andres, thank you. If you're providing any sort of care coordination, love it. And I think what we'll find is that many of you, if not in your specific role, probably in the functioning of your role, are providing that care coordination. The fourth area that you see here on the slide is about cost efficiency. So proper coordination can really reduce unnecessary tests or hospital stays or duplication of services, right? We want to ensure that everyone involved in the person's care is on the same page, and care coordination can help lower overall healthcare costs. And so, really thinking about how all of this gets tied together when we do this well. There are strategies at play that really support care coordination happening. So in order, what does this sort of look like in the day to day? Well, what I'd like to discuss now is how community informed strategies and practices support engagement across diverse populations within the crisis continuum of care. And they're hopefully grounded in fairness and connection and collaboration. And these practices ensure that services, whether it's prevention, early intervention, crisis response, or post-crisis stabilization, ensure that they're responsive, they're accessible, and effective for people from varied populations and backgrounds. right? Community-informed engagement within the crisis continuum means designing with and not for communities, right? It's not about us without us, right? That's a phrase, a saying we often hear and say connected to being trauma informed. It's also connected to being community informed. Effective practices emphasize representation, respect, reciprocity, ensuring services reflect the lived experiences of the populations and really foster trust, healing, and long-term recovery. And so many different aspects intersect here, many different practices, if you will. So we need to ideally pull all of these forward. And this is not an exhaustive list of practices that connect, but it's some of the top ones that I'd like to spend some time talking about today. We really think about family and community connections. This is about how people, we don't live in bubbles. We're connected to family, caregivers, friends, relatives, different kinds of community members. And likely the care and services that get provided are not just going to be with and directly to that person. When we think about the services that we provide to children and adolescents, right? They come often as a package deal with other members of their family. Family might mean biological, family might mean chosen. There's all sorts of different kinds of representation. And part of, I think, family and community connections is around thinking about and understanding the importance of meaningful connections for people. So interfacing in all of this is the idea that when people are struggling and in crisis, there's connections to social isolation or more often to loneliness. With social isolation, it's a condition of total or near total absence of contact between an individual and society. But social isolation is not the same thing to loneliness. Loneliness could be a possible response to social isolation. Loneliness can really be defined as a complex or unpleasant feeling of maybe being empty, alone, or unwanted, craving human contact, but maybe barred or deterred from by various reasons from doing so. And social isolation does not necessarily result in loneliness, right? Sometimes people prefer aloneness or what we call social inaction as a way of life with minimal social contact and can be perfectly happy and perfectly fine. So you could be somebody experiencing loneliness because you were socially isolated. You might be somebody who's in a room full of people and constantly around people and still feel that loss of connection and that loneliness, that subjective experience of the absence of companionship and support. And what we are seeing certainly is that care coordination really helps foster and build connection, meaningful connections. It helps thwart loneliness. And loneliness is fine when it's fleeting. It's a normal human experience. It happens. But when it becomes persistent and pervasive, it has major negative impact on health outcomes for an individual and really puts us in a stress state that often mirrors the same effects as chronic or toxic stress. And it mirrors the same effect as somebody experiencing adversity or somebody experiencing trauma. And so there's an opportunity here when we think about the connections of how we build connections and how we support people. And sometimes those connections are within our crisis continuum system, right? The different staff, the different people, having peers, individuals with lived experience who we can help provide support and hope and guidance, and so much more. We see here another sort of pillar in practice is about recovery and resiliency. And recovery, I love this definition, which really comes out of the Philadelphia Department of Behavioral Health, which really talks about recovery means pursuing a fulfilling life, regardless of the difficulties one has faced. And it can involve the development of or continued enhancement of positive identity, as well as personally meaningful connections in one's community, those connections. Right? And we can facilitate that by relationships, by environments that promote hope, empowerment, choices, opportunities that support people in reaching their full potential as individuals and as community members. And while we might often hear about recovery connected to the lens of the world of substance use, recovery is something that any and all of us can have in sort of any and all aspects of health and well-being, whether that's related to our physical health, our emotional health, anything connected to the way in the context in which we live and function in the world, right? There's so much opportunity there. And connected to this is resiliency and resiliency building. Resilience is essentially our ability to adapt when faced with adversity and significant amounts of stress and return to sort of your baseline or your equilibrium, or perhaps creating sort of a new baseline for yourself. But I really truly believe that that everyone has resiliency, and you kind of have an infinite possibility for resiliency. There are all sorts of skills and ways that we can build up and have within ourselves and how we function in life, which can help us when and if the time arises where there is that sort of adversity or significant amount of stress that comes up. With whole health and wellness and really thinking about integrated care practices, this is really about treating the whole person and not just a person as separate pieces and parts, and really about how that system and the people involved talk with each other. Yes, we each have our own areas of expertise, which should be honored and valued. We have something to bring and to share and to work with our clients and support them. And also, it's important that we know what other people and team members are bringing, what their expertise is, and supporting those efforts as well. Because that's what makes this everything work more seamlessly and fluidly together. Knowing and understanding who is a part of the team, the communication of that, but it's also about recognizing the efforts and the expertise and how we can support those different kinds of areas. It's really, I think, so shocking that way back when, in 300 BC, Hippocrates said, "The body must be treated as a whole and not just a series of parts." It's like mind blowing, right? We're here still in 2025 AD and still struggling to do this well, but I think we're getting better and better at it. I know we're getting better and better at it. And I have that opportunity to see that all across the country, which is wonderful. And yet we still can make this more fluid. And again, care coordination is a piece of this. How we can provide that integrated care and treat the whole person. It doesn't mean we have to do that all within the same walls, or that we are even in walls, right? We can do that virtually, like we're here today. We can do that telephonically. There's so many ways, and it doesn't just mean one organization. It means some partnering with other organizations and how we partner with people. And community informed and trauma informed care and approaches, this is to really think about, to understand being trauma informed is to connect to these other terms, right? Like thinking about what happens in our bodies when we experience stress, can be at the same time what we experience when we experience something traumatic. I talked about when we experience chronic loneliness, it's kind of the same reaction that our brain and then our bodies have. So we're going to spend some more time. I'm going to spend a little bit more time digging into being trauma informed as we continue on today. Whether somebody feels like it's something that they've been through that is traumatic, they might use language that might not be language that connects for them. So maybe it is something that's extremely stressful or something that they feel is an adversity. It really can vary in perception and how people connect. All through this, right, it's about care coordination and care management, right? How we think about and help a person manage and understand their own care and services, how they learn and build health literacy around health related terms and information about their own healthcare so that they can be empowered to be drivers in their own healthcare and not feel like it's done to them or at them, right? It's with them. And health literacy is also about simplifying terminology and maybe eliminating some of the clinical jargon that we used to be so familiar with using that we realized isn't necessary, right? It's so much easier to talk about how when we're using simpler terms that anyone and everyone can understand and not somebody who has to have special training or really take the time to have to stop and explain complicated terms that we could say in much simpler ways. So much of this is also includes many different kinds of evidence-based, which means supported by research. Yes, we know it works anecdotally. Yes, we know from best practices. And also we know from research that supports different communities, different places, things work in different ways. We want to also embody that they're strengths-based, right? So we often work in a very problem-oriented system where we're trying to help people manage and solve problems. And that's important, certainly. And yet also is equally important is recognizing someone's strengths, their skills, their abilities, the opportunities of things that they have been able to provide and do and bring to the table. And through that, also resiliency building, always ever continuing to help people to support the practices that are going to help them in the long run. I didn't mention yet, but data-driven care is on here. And I do want to note that data or data, depending on how you say it, it doesn't have to be a dirty four-letter word. Sometimes people are really scared of it. Sometimes people feel like, oh gosh, it's like math and complicated scenarios, and it doesn't have to be that. Data-driven care or data-informed care, it means that we're taking information, data is just information that we have gathered and collected, and we use that information to help monitor and manage and help people within their own care. We also use information to collect to improve processes and workflows, to understand operations, and the way in which we function. So hopefully we can work smarter and not harder, adding, hopefully cleaning up and not having to add new things without streamlining others, right? So it's really, really important and something that I think we need to really think and focus on and talk so much more about. So all of these pieces, right, they're connected. And especially, I noted I wanted to talk a little bit further about being trauma informed and really thinking about embedding trauma informed components. So let's spend a little bit more time talking about that in detail. So I first want to identify what it means to be trauma informed. So either an individual or a program, an organization, or even a system that is trauma informed, it's when they realize that there's a widespread impact of trauma, or think chronic stress, adverse experiences, adversity, chronic loneliness, right? Any of those sort of suite of words. We recognize that there's that widespread impact and understands that there's many different potential paths for healing. We recognize that there's signs and symptoms of trauma, whether it's in ourselves, in each other as colleagues, as staff, in the clients that we're working with, others involved in the system. And we respond by fully integrating knowledge about trauma into our policies and our procedures, our practices, our settings, what we do, and how we do it. And we don't have to know specifically that someone has been through a trauma to be trauma informed. It's not even about just, it can include treating trauma, but it's not just about treating trauma. It's really about how we interact with one another, how we create a space and an environment that is respectful, where there's good customer service. It really can represent so many different things. And so trauma focused care is more when we're treating specific trauma or traumas, whereas trauma informed care is an awareness of how trauma, or those other words like adversity and chronic stress, can impact all aspects of life. So when we think about components of being trauma informed, they include the following. That you see here, these different components, right? Creating and maintaining safety. And again, as I go through these, think about that first question I asked you, representing what would you want care to look like? So many of you highlighted pretty much everything that's on this list, right? There's creating and maintaining safety. So safety comes in all shapes and sizes. Sometimes we think about physical safety first and foremost, but it's also about psychological safety or emotional safety, right? Like how safe we feel internally. There can be social safety, how we feel safe in and among others. There's moral safety, right? How we feel that our morals and values are connected to and attuned to. There's and other types of safety beyond. And I do think that while all of these are important, safety is one of those things that internally within the brain, within our body, if our brain is not assessing safety of all the shapes and sizes, it goes into a crisis response mode, right? And it starts to stop and shut down some of these other key pieces of the brain and focuses on finding a way to regain safety. And so I think it is a main building block here for the rest of these components. Another component here, right, is establishing trust and transparency, which can mean clear and varied communication and sharing information, being consistent and doing what you say you will do, being upfront and saying it, with that transparency, right? Like, this isn't the Wizard of Oz, there is no man behind the curtain. It is about saying what we're going to do and explaining it, or explaining when we don't have the answer, and saying that and sharing that, and maybe working together to help somebody find the answer. Recognizing and validating and building new skills through engaging with peer supports and mutual self-help is also a huge component here, right? Enhancing collaboration, promoting mental health and awareness, and challenging stigma. And going back to trust for a second, I do also want to note, trust is really hard to give. And it's especially hard if people have had negative past experiences. And often when we're working with people in crisis, they're already waiting for the other shoe to drop, or for a concern to happen, where they've had bad experiences. And so they're on the defensive. And we have to work to really help soothe that and to do something different, hopefully, than the negative experiences they've had in the past. And over time, hopefully trust is given. And if not trust, if we don't want to call it trust, sometimes I like to think about it as being forthcoming. Hopefully we're creating an environment and a space where somebody feels open and free enough to be forthcoming with us, and to share a little bit about themselves and their experience, and to feel like they can work with us in a way maybe that they didn't feel before. So as we continue on thinking about what it means to be trauma informed, and community informed, right? Building collaboration and mutuality, having really true partnerships and leveling the power differences as best we can between staff and the people that we work with. Which can be really hard to do, but we really have to try to do that. And that leveling of the playing field is important. Recognizing that healing happens in relationships. So that human connection that we talked about. Encouraging, empowerment and creating opportunity for voice and choice. People don't things like to do things that are done at them and to them, or being told what to do or forced what to do. People want options. People want to be included, community informed. It's not about us without us. And learning about and understanding various experiences and contexts related to trauma and healing is truly what it's all about. With peer support and mutual self-help, one of the many components that I talked about, right, this is really key for establishing safety and hope. And we can really think about peers or individuals with lived and living experience. You help establish that safety and hope. Building trust, enhancing collaboration. You utilize your stories, your lived or living experience to really promote recovery and healing. And these are integral to organizational and service delivery approach, and understood as really key vehicle for building that trust or that forthcomingness, right? Establishing safety and that empowerment. And there's so many different ways that we can do that and filter in that lived and living experience, whether or not somebody is a formal peer or peer specialist, or informally you have that lived or living experience. So really thinking about it. And Maxine, yes, I love what you say here in the chat, right? Like, it's so important being honest and reachable, available, to be authentic and genuine, right? We shouldn't ever say things just to say them. People sense if we're not being true or, again, our most authentic selves or genuine in that way. We can lose people that way. So really thinking about how we do this and utilize this, and ideally when we certainly are incorporating peer supports, peer specialists into our delivery of services into the mix, as not a separate thing people have to go out and find. These are individuals in vital roles within our systems that help move through in this care coordination provision. So all sorts of ways, these trauma-informed approaches for staff and for partners, really thinking about how do we train people and support professionals to focus on developmentally matched specialized practices, right? So really thinking about how do we train people. Staff need to be trained to know this information, to understand what it is to be trauma informed, and then use the most optimal approaches that make sense to each person and each individual. And this is where sometimes organizations do struggle. If they don't focus on making sure to have appropriately trained staff who are experienced in developmentally matched specialized best practices with priority populations, right? And that again, community informed approach, they will not be appropriately responsive, and their services will fall short. So they need to ensure their staff are knowledgeable and can manage services array of the needs of the clients and then get ongoing support and supervision. All of you who are here today are a testament to the importance and the dedication behind doing that, and to really think about how we all have an opportunity to continually grow and learn and have that growth mindset, which is amazing. Really thinking through and creating and maintaining safe and secure environments, having sensory informed supports, Involving people in decision making, really thinking about how we have frequent visits and touch points in the beginning to engage and build that momentum of care, right? So many of these things that we see here on the slide kind of are follow up to what I was talking about previously. And, there's just looking over this list, some other kinds of things that I want to call out here are about how we're flexible and we're strengths based in our planning. I'm really thinking about using wraparound principles, right? To promote empowerment and self-efficacy. It's important for people who may feel disempowered and or pathologized in the past. Having the family or caregivers involved, continuing to have that voice and choice. With safety planning, this is not just for during the immediate crisis. It's part of safety planning is it's an ongoing sort of intervention and process. It can be part of the warm handoff. It's part of the referral. We should continue to review and update and add to it and help somebody to add to that. And it's all about how we help someone plan for all the kinds of safety, whether or not somebody's at risk or not at risk, or in crisis or not in crisis, right? Really thinking about how we do that. So many things that exist out there that are evidence-based, strengths-based, and resiliency building. Again, this is not an exhaustive list of different things like we talked about being trauma informed. We just kind of scratched the surface with that, truly. It's also about learning different kinds of de-escalation techniques and helping people to reduce escalation. And by people, I mean every one of us. If this is not just something for a client or a patient, it's for ourselves. Each and every one of us gets stressed out and escalated. We have particular hot buttons or activators. Sometimes people call them triggers, right? Like there are different ways that happens. And if we get activated, we are not our best selves and it's hard to help others. It's hard to interact with others. So figuring out ways to de-escalate and to do that, different kinds of models for that, and ways to stay attuned to reducing stress and strategies for that is so important. Things like mindfulness, self-regulation, other things that you see here. There are all sorts of things like relational and attachment-based interventions, problem-solving treatment, solution-focused treatment, and more. I would like to spend some time talking about motivational interviewing. I want to put out there right from the beginning, I'm a very biased person. I train and teach to motivational interviewing all the time because I feel like this is truly a skill and a conversational approach that each and every one of us should have training in. Yes, it was created I think, originally in the addictions field, it moved into sort of general health. It's now used in schools and health, in corporate America and so many other places. But ultimately, it's all about good communication skills and how we help people talk through change. And each and every one of us experience change or decision making or growth constantly throughout life. So, motivational interviewing is a particular way of talking with someone about change or decision making or a particular growth opportunity in order to strengthen their own motivation or commitment towards that change. And if you want to think about it like motivation, great. If you want to think about it like their inspiration for it, okay. I like to think about it as sometimes finding reasons enough to make that change, growth, or decision. In the middle of a crisis, post-crisis, right? Like there are different kinds of changes that people are faced with, decisions that people are faced with. Should I take medication? Should I continue treatment? Should I continue to remain living where I'm currently living? Like there's so many different things. How do I feel about myself or about life and whether or not I still want to continue to stay alive? Like there's so many different decisions and growth opportunities and change. And The use of motivational interviewing, when we use the skills and we layer the skills into what we're doing, because it's not a replacement for what we're doing, we do the things that we do and that we have expertise in. And by filtering in the use of motivational interviewing skills, we can do that in a much better, more enhanced and strategic way to truly help somebody with that change process. So really um, thinking about how, again, it's not a replacement for what we do. And it really factors in, what helps people talk about change more comfortably? What makes a conversation helpful versus unhelpful? But it's about us guiding and helping the person for them to decide. And it really embraces what we consider the spirit of motivational interviewing. These four key aspects of partnership, empowerment, compassion, and acceptance. These four pieces, you'll notice there's so much overlap between these and the principles of being, or the components of being, trauma informed. The spirit of motivational interviewing is really about like the attitude you bring to your work and your communication, your interactions with people. Again, remember, it doesn't have to be with clients. Like, I use MI skills with my nephews, with family members, with the random person in the grocery store who's trying to decide between two melons. I don't know. Like, we can use this anytime, anywhere. We don't have to know that somebody is going through a change or trying to make a decision or has a growth opportunity to use these skills. But the attitude, the spirit, is really about how it impacts the relationship that we have with the other person or people, and about their outcomes. Some people call the spirit of MI the heart set and mindset of the people involved. So let's talk about these a little bit further, right? So partnership. If you contribute a respectful and autonomy supporting conversation, in turn, the other person what they contribute can depend in part on how much they trust you or feel like they can be forthcoming with you. And this can be a big paradigm shift, like we talked about it, right? We talked about before, active collaboration while recognizing the expertise of the person. The the person who has the most expertise about me is me. Each and every one of us, there's no one that's going to have the better expertise than each and every one of us about ourselves. And it's remembering that and valuing that, and then approaching, again, from a partnership, a team perspective. With empowerment, which formally in the spirit in older versions of motivational interviewing, this was known as evocation. But the language has just shifted a little bit to be empowerment, including evocation, which I love here, like that image of the beverage with the straw, because it's all about finding what's within the person, about why they might want to change, what their desires or reasons or needs or abilities around that might be, and help drawing that out of them through strategic and carefully crafted, skillful conversation, and understanding the expertise of that person, and then pulling and drawing that out, which is ultimately going to help help them to move through and make a decision one way or another as to whether or not they're going to change. And so empowerment really is about actively supporting and encouraging the other person's abilities, their knowledge, their strengths, their autonomy, right? All the different strengths and abilities, values, motivations, all of it exists within a person. And our job is to empower each person towards the change that they want for themselves. And we can't do that also without compassion, which is that expression of empathy, a way to understand what it's like for the other person, what it means for them, what their experiences are, to actively promote the other person's welfare and to give priority to their needs, which also means unconditional positive regard and working in their best interest. A few of you mentioned in the chat earlier, right? It's about recognizing what people say and what their experiences are, and accept their information as given. which leads into acceptance, that non-judgmental understanding of the person that they are. They can accept without agreeing or approving. Acceptance that the other person has choice, a sense of autonomy, right? Feeling in control of one's choices and feeling in control of one's own choices facilitates intrinsic motivation. So accepting who they are, where they're at in their journey, belief in the absolute worth of every individual is a piece of that. Um, sorry. So, so much of this comes into there's so much that's connected to motivational interviewing, and unfortunately I don't have enough time to do a full motivational interviewing training, so I'm going to kind of just give some highlights here, which is that part of when we're helping someone and really talking with somebody about change and decision and growth opportunity, it's to understand what stage of change they are in, and to learn and think about that. And so what you see here on the slide, the top part is really about how our actions need to match the person's readiness for change, right? Meeting somebody where they're at. It doesn't always mean geographically, it could mean mentally and in relationship to their readiness. And so each of these areas, each of these stages sort of represents what we can do when we know somebody is in that stage of change. And this particular stages of change, there's different kinds of models of stages of change. This one comes from the Trans Theoretical Model for Change by Prochaska and DiClemente, which really talks about these sort of 5 stages. And ideally, we want to move through these stages in a linear fashion. The reality, though, if you can see all the like weaving lines back and forth, the reality is not so clear and not so direct and step by step. Sometimes we move through, we get to action, and then we're like, maybe not so much. Maybe I'm back in contemplation. Um, so being able to um, being able to understand where somebody is at is really helpful, because we want to meet somebody with their current stage and then know how to help them to get to the next stage of change, not multiple stages out. So really thinking through how we do that. So pre-contemplation stage of change is when sort of change or a decision or growth isn't sort of on the radar. They're not really focused on it or thinking about it. Maybe they're not aware that change is possible. Moving into contemplation, that's when sort of it's brought to the forefront of the mind. They might not be for the change. They might not be, against it. They might be somewhere in between. They're kind of thinking about it. It's just a little bit more on the forefront of the brain. So monitoring and measuring that and kind of that back and forth is all about ambivalence. And that's sort of a key factor of the contemplation stage of change. When somebody's sort of tipping back and forth, right? Pros versus cons, advantages, disadvantages of doing so, upsides versus downsides. Once you're kind of leaning more heavily into the change, then that's usually an indicator that they're transitioning and sort of ready in that next stage of change of preparation. It is what it sounds like. We're preparing to make a shift or a change. And what we can do for that person is to help talk with them, exploring their commitment, help creating that plan with them. It's all about that planning and that problem solving and figuring out what are the barriers that might get in the way, and talking about that there is likely to be setbacks or bumps in the road or complications, right? These are things that we should talk with somebody about when they're in that preparation stage of change. When somebody's still not sure if they're ready to make a decision, change, or growth, it's not helpful to be like, and here are all the problems that you're going to face, right? We do want to wait till somebody's sort of in that preparation stage of change to help talk about that and to plan for it, and then it helps build success in that process. This is something we want to keep in mind in the work that we do, because, very often, due to the nature of requirements for our job, due to insurance companies, right, and payers, different kinds of regulatory requirements, we have to do goal setting or goal planning or create care plans or treatment plans or service plans with people, which in theory would happen when somebody is in sort of that preparation stage of change. And yet many times people are still very much in that contemplation stage of change where the ambivalence is very high. And so really thinking about, it doesn't mean we don't do those things when we need to do them, we do them, but how we do that and how we help somebody, it helps us hopefully to help them formulate what kinds of goals and what kinds of support and the kinds of things that they might do. Somebody who's still in contemplation is really still very much exploring options or exploring whatever possible change is at the forefront of their lives right now. So really thinking about that and helping them. And then once that plan is in place and that preparation has happened, somebody moves into the action stage of change. And over time, whatever they're doing, at first it's hard. First, you have to really think about it. There might be some bumps in the road. There might be some roadblocks that come about. That's okay. Hopefully, you've talked through that and helped that person. They're going to keep going, and over time, it gets easier and easier. They no longer have to actively think about it, and it starts to transition into an everyday occurrence. And that's when it becomes more of that maintenance stage of change, when it's actually now harder to not do it than to do it, or where that change or that decision, that growth has been consolidated into the life, into their lifestyle. So all along the way is understanding this and then working and utilizing skills of motivational interviewing, the skills of understanding and listening for specifically change talk, which is the things that people say in favor in the movement or in that direction of change. When somebody gives you talks about a desire for that change, and we use the acronym DARN CAT, right? Desire, ability, reasons, need. That's the darn of darn cat. And then, or a commitment towards it, an action towards it, taking steps. That's the cat part. These are all sort of indicators in conversation of somebody that is using change talk versus sustained talk, or the things that we say that are in favor of like the status quo, of keeping things the same, of not making that change. So in the conversation, we're using the ORs. Some of you chimed in that you love the ORs, which is great. I love the ORs too, especially the R of the ORs, which stands for open-ended inquiry or open-ended questions, affirmations, reflections, summaries, right? Asking open-ended questions, affirmations, saying, highlighting a strength, a skill, or an ability to somebody, like saying that to them, about them. Reflections, statements, listening statements, where we mirror back what we heard or what we understood the person to have said. And then summaries. These don't have to just be at the end of interactions or conversation. We can, at a stopping point, we kind of gather what has been done sort of productively, especially highlighting areas of change for that person, and then continuing on to check in and say, what else, or where does that leave you, or where might you make a shift or a change? So all along the way, there's so much, right, to this that really plays a role in how we provide services, these strategies for providing care and good care coordination. We talked about empathy, but I do want to highlight this particular quote, right? Brene Brown said, "In order to empathize with someone's experience, you must be willing to believe them as they see it and not how you imagine their experience to be." So many of these strategies have a focus on engagement, which is about forming and keeping a connection. And this is about how we express wanting to truly understand the other person so that they know that we understand them. It's not just about being friendly, right? They need to know that they can trust us or be forthcoming with us, that you understand some aspect of their experience. And through that, right, it doesn't just happen at the beginning of connecting with somebody, but it should be all throughout the time, throughout that engagement and time spent with that person. And this, as we carry forward and think about the warm handoff, it's all about what we do and how we help people and connect people to further services. A true warm handoff, if we're using like a true definition of a warm handoff, is where the entity or person that is referring and the entity or person that is accepting the referral in real time is together with the person being referred, or family, or or group. It's not just not always one person or one individual, but where they're all together, either in person or virtually or telephonically in real time. That is a true warm handoff. Unfortunately, it's not quite a warm handoff for me to say, oh, I have this wonderful colleague. She's great. She's going to help you. Her name's Megan. She's right down the hall, 5 doors down on the left. Feel free to go there after this, or, you can see her next. Unless I walk that person down the hall and I say, hey, Megan, I have this person that I really want to connect you to. I think, it'd be great because of X, Y, and Z. Unless we do that, it's not a warm handoff. Maybe lukewarm. I don't know. It's definitely not. It's all about transferring the individual directly and personally from one service or provider to another, and not just giving the person the name or a phone number, right? It's ensuring continuity and safety and trust by keeping the person supported and connected throughout that transition. Part of what you're also doing is, in a quick way, where we engage with people and we build a rapport with somebody. And if we're doing this in a warm handoff, we transfer that rapport right on to the next, which makes that transition smoother. People get a little less anxious. They're more likely to connect. We can't necessarily do warm handoffs for everyone every time. So it's important in your teams and in your work and what you do to really think about and talk about, who do you especially want to ensure that there are warm handoffs happening for? Individuals that like are at a higher risk for falling through the gaps or the cracks, right? People who you think really could benefit from that connection, or maybe have previously not made it to a connection in the past. Those are some of the things that you want to talk about. And I do have some examples here to talk through within the crisis continuum. And I love, people are making some really great comments in the chat. So thank you for that. Really, really aligning with a lot of what I'm saying. So I appreciate and love that, to see that, and that you're sharing that. But let's take a look here. It's just some examples. This is not the only kinds of examples, but let's say you are in the pillar of someone to call, right? Maybe you're a crisis counselor who's initiating a handoff, and a mobile team or stabilization center receives that handoff. The counselor stays on the line until the mobile team arrives, and then they follow up after transfer. That would be a warm handoff. And by the way, that follow-up piece is key. We not only do we want to do that warm handoff, but regardless of how we are transferring somebody, we do want to follow up. We want to ensure somebody got to where they're going and sort of close that loop, if you will. And sometimes it's to stay informed. Maybe we're not closing things. We're staying involved and continuing. Maybe somebody's returning to services, or there's another way we're continuing to stay connected and involved. We're not just passing it on and that's it, depending on your role and the services that you provide. Another example here, right? If you're in the pillar of someone to respond, maybe you are a mobile crisis team. You're initiating a handoff. So a crisis facility or an outpatient provider receives that handoff. The team accompanies the individual to the facility and introduces them to the staff person and stays until they're settled. Right? Or maybe we have a virtual meeting where people get to meet in person and connect in that way. There's so many different examples. A third example here under a safe place for help, right, might be a crisis stabilization unit. Staff can initiate the handoff. Maybe an outpatient or community-based provider receives that handoff and the staff arranges a follow-up appointment. They coordinate transport, check in post-discharge. These are just some examples. But ultimately, what we're trying to do is to prevent people from falling through the gap. We want to prevent those gaps in care. If a warm handoff doesn't occur and somebody is at a sort of a higher risk of falling through, or certain follow-ups don't happen, people fall through and don't get connected. They have gaps in care and then crises can resurface. So when we think about how someone connects to any of the crisis system pillars of either someone to call or somebody to respond or a safe place for help, right? Each of those are critical moments. A well-prepared referral or a strong handoff is equally important to the role of receiving partner or provider, organizations, in making that transition smooth, supportive, person-centered, and preventing gaps in care where individuals might disengage or deteriorate in some way, right? We want to build that trust, that safety, all the connections, all these pieces. All of this is through care coordination. So we do want to build and develop successful partnerships. And we want to, it's not only important to establish partnerships with other organizations, other entities in the community, different kinds of services, but it's also about maintaining those partnerships. So where do we start, right? Like part of it is assessing the landscape of services. Where do you know where to refer to and when? Who are your contacts? Are you building relationships with those partners? Are there any gaps in partners that you need? This is especially important when we think about our rural and frontier communities. It might not mean that other organizations or partners are close by. It might mean they are much further away. Like I'm thinking about the work I do in Montana all the time. Like the nearest provider is sometimes like 3 or more hours away, or we have to do things telephonically or virtually. So really thinking about and assessing what are the needs. Do we have places, people to refer to connect with? And are we building and maintaining those partnerships? Are we finding ways to ask community members for their input in this at town meetings, community listservs, community needs assessments, having people meet and greet and make sure that we're really identifying and thinking about how we are community informed. So do we have connections for all the communities that we serve, all the individuals that we serve? And then we strengthen those current partnerships by really helping to connect and to see how things are going. And there's different ways to do this. But we do want to check in and see how things are going. For existing partnerships, there's actually I think a really great tool that we're gonna add, or Jennifer has already added it to your chat. This is a path. It's called the Path Assessment Tool. It's a tool with that many community-based organizations can use, called the Partnership Assessment Tool for health, and it's designed for community-based organizations and healthcare organizations in partnerships. But there are other kinds of organizations you can pull from it and learn from it. But it is about how we connect, we communicate regularly, we see we talk about what's working and what's working well and what's not, right? And to learn and tweak workflows or how we do warm handoffs or so on, right? Enhancing those processes and thinking about how we continue to work on different kinds of partnership workflows. There are lots of items to discuss in that, and thinking about like documentation, how we share consents. All of this is part of that care coordination. All of this requires communication. and hopefully not just functioning, but good functioning, right? There's many ways to have strong communication as partners and as team members, including we talked about sort of person-centered language, having team meetings, daily huddles. Huddles, don't have to be long, 5 minutes, 10 minutes, checking in. We could do that electronically, virtually, through emails, maybe through the use of internal electronic health records. We do that as warm handoffs or warm referrals, which would be that like sort of next step down. Being able to really think about how we do this, how do we build those partnerships? It's all about relationship building, and part of that is demonstrating our value, communicating, talking, and making sure what we're doing is truly optimized. We want to filter all of these concepts in together. And I know it might feel like a lot to hear it all kind of packaged in this way. I have no doubt that each and every one of you are utilizing many aspects of what I've covered, though. But we want to really think about how do we do that in a synthesized way? And it does mean connecting and communicating with one another and collaborating and figuring out what we need to improve upon and not being scared to kind of talk about that. So the work ahead, we need to think about how we continue to train people. We want to really utilize peers and lived experience and really think about training peers and clinicians and staff in warm handoffs and with community partners, faith leaders, cultural liaisons, right? All of that to strengthen and trust engagement. We want to design protocols with people with lived experience to reflect real community needs. We want to measure what matters with clients and families, right? That data to ensure continuity and not just contact. And we want to remember that every crisis is an opportunity for connection, right? Those meaningful connections. And every follow-up is a moment to rebuild trust or to help people feel like they can be forthcoming. And every warm handoff is a bridge between systems and people. And when care feels like community, recovery becomes possible for everyone. So I thank you so much for your time. I really appreciate the comments and the engagement in the chat.